So this evening's presentation is looking at all or many aspects of dental safeguarding. I want to thank Simon Earnshaw particularly for helping us put all this together. It's a huge amount of work to get everybody lined up and engaged in these things. And I'm going to introduce the panel in a couple of minutes. This evening's presentation, we have had a number of questions in advance and we'll go through those towards the end. Okay, so I'm going to get in order on my screen. So quick introduction, Millie Doshi, just tell us a little bit about yourself.
Hi Rob, thank you. My name's Millie Doshi. I'm a special care dentist and I work in East Surrey and in London. Thank you. Okay,
Simon Earnshaw.
Yeah, I'm a dentist. My role is a supporting role tonight. We've got a great group of people to communicate with you about safeguarding. I'm looking forward to it myself, in fact.
Jenny.
Hi, I'm Jenny Harris. I'm a consultant in paediatric dentistry based in the Community Dental Service in Sheffield.
Deborah.
Hi, I'm Deborah Manger. I'm Deputy Dental Dean in the Midlands and East, and prior to this I worked for 30 years in the Community Dental Service in Northamptonshire.
Jasmine.
Thanks, Robert. Hi, I'm Jasmine Murphy, consultant in dental public health, working with NHS England and Improvement in the Midlands.
Okay, and last but not least, our chair for this evening, Kenny, who put us all on our toes by not being able to get in properly. So, Kenny.
Hello, everyone. Thank you for the invite to chair or facilitate this event. My name is Kenny Gibson. I'm the National Head of Safeguarding for your NHS, and I'm not a dentist.
Okay, so I think Kenny's going to start with a short presentation first of all.
I am. Good evening, colleagues, and welcome to your dental masterclass on safeguarding across the whole team. My name is Kenny Gibson, and I'm your facilitator this evening, and I'm also the National Head of Safeguarding for the NHS. We'll hear some case studies and we'll hear some excellence and practice from dental colleagues over the next hour and a half, 2 hours. And that will be supporting you to understand how to be brave and how to be courageous around safeguarding. These workshops have been brought together and facilitated at level 3 for your continuing professional development and system leadership. Before we go to the presenters and their case studies, I want to recognise a massive thank you on behalf of NHS, patients, citizens, a massive thank you for all you have done, your team has done during COVID. And I want to recognise before we start that in that massive ask during COVID, we, us, are all exhausted. And in that exhaustion, we must each inspire each other to go a bit further, be a bit braver, be a bit bolder in how we deal with, how we recognise, and how we process safeguarding. It is a matter of fact that as we've come to unlock and recover from COVID, some of the patients you see and some of the colleagues you re-meet with, particularly the patients, this might be the first moment that anyone clinical or representing the NHS has had eyes and ears and a view on these people, these children, these adults over the last 2 years. And so as we listen to these presentations and as we listen to the case studies, let's put a lens on that and let's think about how we can make every contact count as we invite patients and citizens into the dentistry system, your services, and onto the chairs. Beyond question, COVID has been a microcosm of our society. It's in fact distilled 10 years of safeguarding into 2 years of trauma. And I don't say that lightly. In most homes, there has been pressure cooker moments where even the relationship turned into abuse, violence. And so we need to appreciate that we're talking tonight about care. We're actually talking about our self-care and indeed the compassion colleagues. The next few months will be a moment when we can listen to colleagues, disclose traumas, and we have to begin listening to things that are reported. We've seen a rise in domestic abuse. We've seen a rise in violence towards women and girls. We've seen a rise in child sexual exploitation and serious violence. And part of what we must do from tonight is challenge our own and our colleagues' unconscious bias in order to ask a suitable question that is trauma-informed. What I've learned to do with my trusted relationship as a mental health nurse and as a midwife is ask not the medical question, how are you? What are your symptoms? But to begin asking my colleagues, my friends, my family, my community members, and yes, my patients, a very important question. How safe do you feel at home? That question, how safe do you feel at home, has been developed through the lived experience and the helplines of trauma-informed practice. And by doing so with colleagues, families, communities, and patients, we will have a social movement that overturns and deals with people's unconscious bias. It is okay not to be okay. It is okay to ask these caring and compassionate questions. Because only then do we know who the victims are. Only then can we begin supporting the victims and survivors of domestic abuse, child sexual exploitation, neglect, and violence. Only then can we make referrals to the proper people. Because the other thing I've learned about safeguarding in my 42 years as a clinician is no one person can fix that citizen's shit life syndrome. You cannot rectify, you cannot apologize for the years, the months, the decades of neglect, abuse, exploitation, and violence. What we can do is we can put them on a strength-based journey with support of named GPs, of the multi-agency safeguarding hubs, of peer advocacy services, all of which can be found in summary form on the NHS Safeguarding app. So if all we do tonight is download the NHS Safeguarding app and go on each page and find who our trusted peer advocacy services are, we will have flourished a community of practice. But I also want to talk to you about referrals and making contacts with the named GPs. You cannot have a strength-based approach with victims and survivors of abuse, exploitation, or violence on your own. So key contacts for me have been the named GP in the practice, or indeed the multi-agency safeguarding hub. But I want us to be braver. If that referral to the multi-agency safeguarding hub, if that referral to the named GP has no response within 5 days, please follow it up. If that referral to the multi-agency safeguarding hub is met with a decline of threshold, again, escalate it. Don't give up because someone else doesn't feel your intuition and your bravery at escalating something for a referral. The final thing I am certain will be covered this evening is data sharing. Many clinicians are still really concerned about data sharing to people outside the NHS. But it is critical you share your data as a referral, and it is even more critical you share your data if you're going to protect these citizens, these patients, or indeed colleagues with and from their abuse, their neglect, their exploitation and violence. And there are ongoing concerns professionally. Am I allowed to? Does the GDPR allow me to? So during the talk, we will be inspiring you to think about data sharing, because you can, you will, you must data share in order to protect. So let's now begin listening to our colleagues who have vast amount of experience safeguarding children, vast amount of experience safeguarding adults, and system leadership as well. Thank you very much for attending and giving up 2 hours. Remember, this is your opportunity to learn from your colleagues, and this is our collective opportunity to begin a social movement that NHS dentistry does and will continue to safeguard citizens. Thank you.
Thank you for listening. And now we're going to go on to our first speaker. Robert, do you want to say who our first speaker is?
Yeah, first speaker. Yeah, so yeah, sorry for everybody, but Kenny's got connection problems this evening, as you may have noticed. So the first speaker is Jasmine. So pass over to Jasmine.
Okay, sorry. So good evening, everyone. Yes, as I introduced myself earlier, I'm Jasmine Murphy, and I will be talking you through the Safeguarding Toolkit that was published in 2019. So what is this toolkit about? The document recognizes the importance of understanding safeguarding issues. It also describes different forms of abuse and the roles and responsibilities for the dental teams, and signposts to training and pathways to be followed if we are concerned. All of us deserve to be safe and protected from harm, but sadly, high-profile cases in the media have highlighted that abuse is still happening, and often to the most vulnerable in society. We hear of child abuse, elder abuse, modern slavery. These cases are upsetting for all of us, and we wonder how these events could occur without anyone noticing. Surely someone knew something about the abuse and had noticed something. Why did no one act, and why were they not listened to? By working together, we can all make a difference in safeguarding vulnerable people. It is the duty of all citizens to call out abuse where they see it and act to protect those who are being harmed. Therefore, the dental team has a statutory duty of care to all patients and the wider public in ensuring that safeguarding arrangements are in place and are acted on. To this end, dental teams should not feel inhibited to raise a concern. Sometimes a feeling or noticing something that just doesn't seem right can play a vital part in the jigsaw that can make the difference to someone in a vulnerable position. In some cases of abuse, contacts with healthcare professionals could have made a difference at key moments in time. Now, for safeguarding children, this is enshrined in the Children Act of 2004. Section 11 places duties on organizations and individuals to make arrangements for ensuring that their functions, including services that they contract to others, are discharged with due regard to the need to safeguard and promote the welfare of children. For adults, the Care Act of 2014 provides guidance of adult safeguarding. It cites neglect and acts of omission as behaviour which could give rise to a safeguarding concern. Now, local safeguarding partnerships and boards make arrangements to work together for the purpose of safeguarding and promoting the welfare of children, young people, and adults in their local area. Together, they will provide assurance that local safeguarding arrangements are in place as defined by legislation and other statutory guidance, help and safeguard children and young people and adults with care and support needs. They work collaboratively to prevent abuse and neglect where possible, ensure agencies and individuals give timely and proportionate responses when abuse or neglect has occurred, and that safeguarding practice is continuously improving and enhancing the lives of local children, young people, and adults in the area. So it is without a doubt that the dental team is in a position where we may identify signs of abuse or neglect or hear something that causes concern. The General Dental Council's standards for the dental team requires registrants to raise concerns for those at risk of abuse or neglect, and the Care Quality Commission specifically seeks assurance of the dental team's competence in safeguarding them. So there are 6 main steps to discharging our safeguarding duties. Firstly, to recognise and identify potential abuse. Then to speak to the child, young person or adult if concerned, where this is appropriate to do so. Then to raise concerns or seek advice. Then to keep accurate written records. Then to report concerns to the appropriate person. And then routinely communicate with all professionals. It is recommended that each dental practice should have a named safeguarding practice lead. The SPL, the safeguarding practice lead, is not expected to be an expert in safeguarding or deal with all safeguarding issues, but rather to be that central person in the practice with oversight of safeguarding matters at the practice. They should ensure staff recognise their training needs, undertake appropriate training, and they should also ensure that staff can access appropriate support and advice on safeguarding matters. Now, it is important that the identification of training needs should not just be one event, but it's an ongoing process forming part of their continuous professional development, and therefore the training should feature in their personal development plan with appropriate clinical supervision and evaluations. Practices should also name a freedom to speak up guardian, who should be independent of the line management chain and therefore not be the direct employer. It is also important to ensure that staff know who they are and how to contact them. So NHS England can be contacted by any member of the dental team with a concern, as they hold the status of a prescribed person under the Public Interest Disclosure Act. And the GDC's confidential helpline on 0800 668 13229 can also be contacted by dental registrants if they are unsure whether they have a concern. Now, where a practitioner does not speak the same language as the patient, or the patient has limited proficiency in English, or if they require British Sign Language, the services of an interpreter, either in person or through a telephone-based service, if this is deemed appropriate, should be engaged. There are situations where patients may request that family members, friends, or untrained members of their community interpret for them. However, the risk of relying on someone close to the patient in what may be a highly personal and confidential situation is that they may not be able to interpret accurately and may allow their own views of the situation to color their translation. It may also be difficult or even impossible for the patient to disclose issues such as abuse in their presence. Therefore, it is not considered good practice to use family members, friends, or untrained members of the community as interpreters, as there can be no assurance of exactly what is being said and translated, especially where abuse has occurred. Not providing an interpreter can affect patient experience and health outcomes, increase missed appointments, and make consultations less effective. And importantly, under the Equality Act, it can also be considered indirect discrimination. So where dental practice does not use an interpreter, the reasons for this should be clearly recorded. They must have considered the test of due regard under the public sector equality duty. This, Kenny just mentioned this earlier. Did you know about the NHS Safeguarding app? This is a comprehensive resource for all healthcare professionals, carers, and citizens. It provides 24-hour mobile access on up-to-date legislation and guidance across the Safeguarding Life course. It also provides information on how to report a safeguarding concern, and even has a directory of safeguarding contacts for every local authority in England, which is searchable by region. So it can be accessed via Apple, Google Play, or can be downloaded by visiting your device's app store and just searching for NHS Safeguarding. Now, it is also important that we know about the LADO, which is the Local Authority Designated Officer, and also PIPOT, the persons in positions of trust. Now, the LADO, which is, as I mentioned, the Local Authority Designated Officer, has to be contacted within 1 working day in respect of all cases in which it is alleged that a person who works with children, i.e. a member of staff, has either behaved in a way that has harmed or may have harmed a child, or possibly committed a criminal offence against or related to a child, or behaved towards a child or children in a way that indicates they may pose a risk of harm to children, or behaved or may have behaved in a way that indicates they may not be suitable to work with children. Now, the PIPOT is the process for decision if a disclosure needs to be made to the employer or registering body like the GDC of a person working in a position of trust with adults at risk. So, as I'm sure you're all aware, there is wide-ranging evidence in relation to the harm, abuse, and neglect that people with protected characteristics experience, in particular children and vulnerable adults, with many reports identifying widespread failures of care for those in the most vulnerable of circumstances. This is compounded by the fact that people with protected characteristics and who have a range of multiple and complex service requirements may be in positions that increase their dependency on others and makes them less able to protect themselves from harm or abuse. We should also appreciate that the term vulnerable adults does not refer to a homogeneous group, as any person can be in a vulnerable situation, and a person's age or disability does not in itself make a person vulnerable. Therefore, nurturing professional curiosity is fundamental to keeping children, young people, and adults safe. So if you notice any changes in behavior, in appearance, in mood, any signs of injury, emotional distress, or anything that makes you wonder if something is wrong, be curious and ask the question. What's happened? Do you feel safe? Try to find some pragmatic solutions for disclosure. It does not require anyone to be interrogated, but it does involve the critical evaluation of information and the maintenance of an open mind. We should be listening to what is being said and also looking out for non-verbal clues such as body language. We should also keep detailed records of our observations to help in the identification of any safeguarding concerns. We know about the Mental Capacity Act. The Mental Capacity Act protects an adult's rights to make their own decisions for themselves, even if we as professionals disagree or think that their decision is unwise. Decisions made regarding safeguarding and participation in the safeguarding process must be made with, in line with the Mental Capacity Act. And there are 5 statutory principles which we must have regard for. And they are there on screen for you. So, the Safeguarding in General Practice Toolkit highlights how dental services can intervene by connecting safeguarding with good practice in meeting the needs of those at risk and therefore work to reduce health inequalities. We do not need to know about the execution of safeguarding referrals in detail, but we must know what to do when abuse is suspected, how to act to prevent abuse, and when to make a safeguarding referral. There are many resources in the toolkit, such as a sample safeguarding policy and also a safeguarding flowchart, amongst others. So do have a look through the toolkit. There's also a domestic abuse case summary, child sexual abuse and exploitation information, facial, oral and body maps, female genital mutilation resources, and safeguarding competencies for children, young people, and for adults, and also free safeguarding training opportunity links. So in order to implement the recommendations within the Safeguarding Toolkit document, we need to be asking ourselves some questions at the practice in order for us to continually advance equality by linking empowerment to safeguarding and ensuring that communication is both accessible and culturally competent. So the toolkit will take you through some pertinent questions that you need to consider. Have all members of the dental team, clinical and non-clinical, read the document? How will the document, along with the web links provided to pertinent supporting guidance, resources, free training opportunities, and video links, be discussed in team meetings? And how will they be embedded into practice? Does the practice have a named safeguarding practice lead? And do all members of staff know who they are? Does the practice have a named Freedom to Speak Up guardian who is independent of the line management chain and not the direct employer, who can ensure that policies are in place and that staff know how to contact them? Do all members of staff know how to access the NHS Safeguarding app to search for local safeguarding contact details? Does the practice have a safeguarding policy, and is it regularly reviewed? How are members of staff safeguarding training needs identified? And have all members of staff undertaken the appropriate level of safeguarding training? And that's it from me. Thanks for your kind attention. I shall now pass you on to Jenny Harris, who will take you through some case studies and highlight the importance of recording was not brought rather than did not attend in our clinical notes. Thank you.
Thanks, Jasmine. That was brilliant. Okay, so Jenny, you go next.
Over to Jenny, who will talk to us about child safeguarding, the importance of child safeguarding. Thank you, Jenny.
Thank you. As Kenny said, my remit is to talk about safeguarding children, and I'm planning to speak for about 20 to 25 minutes. And the way I'm going to do that is, first of all, just start off with 3 fundamental or founding principles, then look at 3 cases that are from my own practice and include one that's come up in the last year, another where I've been following a family for 15 years, and then finally I'll look at 3 flowcharts or tools that I find useful in my own clinical practice. So a good place to start is with children's rights. Children themselves learn that they have a right to be looked after and to not be hurt by other people. The United Nations Convention on the Rights of the Child says that they have a right to be protected from all forms of maltreatment, abuse and neglect. And they also have a right to the enjoyment of the highest attainable standard of health and facilities for the treatment of illness and rehabilitation of health. So I think you'll agree that there's a lot there for us to consider in dentistry. The second principle, it's helpful to start with some definitions, and I think sometimes dentists tend to get a bit muddled about this, but safeguarding children talks about a very wide range of measures taken to minimise the risks of harm to children. Taking action to enable all children to have the best outcomes, not merely protecting children from maltreatment. But within that safeguarding umbrella is child protection activity, where we're protecting specific children who are suffering or are at risk of suffering significant harm. And I think it's helpful to be aware of that distinction and the different meaning of those words, particularly when we come to refer and we're trying to work out what action we're expecting social care to take. And then a third founding principle, of course, oral health contributes to overall well-being. And the impacts of poor oral health are well known to us: pain, infection, disturbed sleep, difficulty eating, missing school, and particularly in younger children, lower body weight growth and quality of life. And those things improving when dental care has been provided. So those 3 founding principles, I want to now take you through 3 different cases. But in picking those, I've had to consider, what to choose for the limited time available. And if I think back over the past 15 years, the striking thing about the safeguarding cases that I've been involved in is the very wide range of issues. Dental neglect is by far the commonest issue that we face, so often delays seeking treatment for dental pain and infection. But they range across a whole load of things, including parental alcohol and substance abuse, resulting in inadequate supervision and repeated injuries, including dental injuries. A child missing from education at a time when I'd never even heard that was a thing. And then even a disclosure of family violence while I was just taking a history about a child who'd witnessed his own father self-harming in the family home. So there's a whole range of things that can present in our surgeries, but I think backed up by evidence not from the UK. Unfortunately, we don't have data to show what dentists refer to social care, but a nice study in Sweden which showed overwhelmingly that it was dental neglect that was the issue. Amongst 147 reports by dental professionals to social care, 52 were for neglect, dental neglect, and 93 for what they termed as deficiencies in care, failure to attend appointments. So these are the big issues for us, and so that's what I'm going to focus on. So the first case I want to share with you was of an 8-year-old girl with autism, accompanied by her mother, who was referred to me for routine care. And this followed an urgent general anaesthetic a few months previously, where she had been suffering from pain and had actually stopped eating. And this was one of the most urgent cases that the team I work with, across the community dental service, but also with colleagues at the dental hospital. And we had to arrange a GA very soon, at a time when GA lists were very difficult to get hold of, because she'd stopped eating as a result of her dental pain. So that was the background, and she came to me in order to establish some routine preventive care so that she might become a regular patient. And this was after the 3rd pandemic lockdown, so about sort of spring of last year, with the school summer holidays approaching. And it was when I asked my routine question, who lives with you at home, that it all came spilling out. The mother explained that her husband had died recently. This child had siblings aged 9 and 6, and the older brother, a 9-year-old, also autistic, had become very fearful and angry, fearful of hospitals in particular. And that was difficult because they had a lot of appointments to attend. And while I was keen to acclimatise her to treatment and start applying fluoride varnish and get preventive care underway, it was very obvious that that wasn't the main issue for this family. And so what did we do? Well, we offered support immediately. I explained to her that I thought there would be something that we could do to help. It was difficult to discuss with the child already distressed in the surgery, having reached the end of her attention span. And so what we did was rebooked for the mum to come again on her own. And in advance of that, my dental nurse prepared an early help assessment referral form. So put in all the family details into that. And mum came, and me and the dental nurse met with her in order to finish completing the form and to gain her consent to referral for early help. And in that, the main task was identifying the main issues that we were seeking help with. We'd looked at the Safeguarding Children Partnership website, our local Safeguarding Children Partnership, to see what kind of support might be available. And the key issues seem to be bereavement support, but also helping the mother with her language needs, because she'd relied on her husband for translating all the letters from school. And so things like that had become unmanageable for 3 children needing to return forms to school all the time. So in this case, we then sent off our early help assessment request, and a few weeks later chased it up and found that the multi-agency support team had undertaken to support the family. And they replied, the case has been allocated to a worker who is supporting the family. And I think that was the outcome that we were hoping for. So I'll move on to another case. This is the case where I've now known this family for around 15 years. This boy was referred to me at the age of 5, again, autistic, non-verbal, and he was referred by a health visitor. Already at that stage, he'd had a previous dental general anaesthetic for extractions, but he already had caries in all 4 of his 2nd primary molars. Things didn't seem quite right, and his mother perhaps a bit unresponsive to his emotional needs. This, of course, 15 years ago, when we were less familiar with safeguarding issues compared to now. And he became one of the first cases I treated with preformed metal crowns using the Hall technique. So an easy case to choose when you've got the D's extracted and 6 is not yet through. And I was rather pleased that those teeth now seemed safely protected. And he was potentially cooperative for having fissure sealant, so I was keen to see him again. But then he, at the end of this course of treatment, he then missed recall appointments. I suppose I had a funny feeling that this was a vulnerable family and that I would like to do more to follow things up. We had no response to our letters and phone calls inviting them to make a further appointment. I phoned his school. They had no concerns. I then phoned the general medical practitioner who looked in his records and found that there was a string of missed appointments at the Children's Hospital. And so after discussion with her, we decided that it would be appropriate to make a referral to Children's Services. And so I did that. And although they didn't take it down a child protection route, they did contact the family and prompt them to make another appointment. And so following that, we were able to re-establish contact, re-establish regular appointments, and he came back to us. We were able to fish seal the sixes, establish a nice rapport with his new stepfather, who was managing all the appointments for this now quite large family. And so time went on. Through our alert system, we came to find out later that the children were the subject of a child protection plan. And the background to that was that there had been inappropriate discipline in the family, physical punishment. But after a time on the plan, they were removed from the child protection plan, other than one of the older girls who had been running away and was thought to be at risk of sexual exploitation. So my patient, by the age of 14, had developed no new caries. He'd now was able to take care of his own oral health, and although he never became a brilliant toothbrusher, he was using fluoride toothpaste regularly, and I think, you know, very pleasing outcome dentally at the age of 14 when you consider the situation at age 5. And I passed him on to adult services. He's now, I guess, around about 20. I'm seeing some of the children younger children in the family, and recently was distressed to hear that several of them have now been booked in with me, but we'd had a phone call to say that they would be coming with mum, not dad, because there had been, one of the children had made a disclosure that they were being beaten with a slipper at home. And so now dad is living away from the family and proceedings are underway. So I think they're a long story, some positives, but also emphasizing the importance of retaining your professional curiosity, even when you think you have established a good rapport with the family. You need to still keep your antennae out. So my third case is this boy. Will join the story when he was 12, at which point he had cancelled, or his mother had cancelled 3 consecutive appointments for general anaesthetic extractions. I should say comprehensive dental care under general anaesthesia, because it was not just extractions, but also fissure sealants that were planned. Prior to that, he had missed a number of appointments, but we'd managed to get him back into care. I'd made the referral, and he'd been on the waiting list. You can see the chronic abscess related to the upper left A and the displaced permanent incisors, something you really don't want to be seeing in a 12-year-old. This should have been dealt with many years before. So 3 cancelled general anaesthetic appointments, and so he wasn't going to get another one without a reassessment. We asked the paediatric liaison nurse to check safeguarding alerts, and there was only years back a history of parental substance use when he was a baby, and nothing since. And so at that point, we were contacted by his school, who had concerns, and they had made 2 referrals to children's social care, but had never met the threshold for child protection action. And so I had to consider, you know, what did I think was going on from our point of view? When I'm concerned about dental neglect, I think about three different things. And in this child, all these three criteria were met. There was obvious dental disease, even that would be obvious to a layperson or non-dental health professional. There was significant impact on the child, primarily in this case on his appearance, but also with the retained roots of the E's that you saw in the previous photos, very likely that he had had dental pain in the past. And then thirdly, he'd not been brought for dental care, had access to treatment, but persistently was not being brought. And so on that basis, I considered him to be at risk of significant harm because of dental neglect and made a child protection referral. The social worker, as a result of that referral, then supported the family to attend for reassessment, and we were able to discuss mum's anxiety about the general anaesthetic. She was very worried that he wouldn't wake up from the GA. There was no other family, just him and her. And so those were important issues to address. But that wasn't the only issue. We were able to make things easier for them. And in the picture, you can see my very helpful, flexible orthodontic colleague was willing to annotate the photographs I sent in, which saved him and mother a visit to the dental hospital and simplified things very much so that we could make sure we had our treatment plan right, now including a permanent tooth extraction as well. And we agreed another date for the general anaesthetic. And as a result of that, the GA treatment was completed and remaining only for us to recall him for preventive care. He missed an appointment before the pandemic. We were unable to contact them during the pandemic to do remote telephone check-in appointments because mum keeps her phone switched off. And he wasn't brought when we recalled him again after the pandemic or after the first series of lockdowns. And he's one where at the moment we've got to a was not brought for stage, which I'll say a little bit more about in the future. He's in a very different position dentally because his treatment has now been completed and it's just preventive care that he's now missing out on. So I've talked about three founding principles, three cases. I now want to make mention of three flowcharts or tools that I use in my clinical practice, two just very briefly in passing and signposting you to where you can find out more information. And then I've been asked to say a little bit more about the was not brought approach to managing missed appointments. So firstly, child protection in the dental team. I think some of you will be aware of a handbook that was circulated back in 2006 that had an accompanying website, and it was updated in 2013 and is now hosted within as a sort of standalone website within the British Dental Association's website. And that talks about responsibility, recognising, responding, reorganising and resources with quite a lot of clinical information to support your decision making. But within that, a flowchart that describes the requirements for assessing the child and where you can go for help, but taking quite a broad approach where you then decide whether you still have concerns and follow down the left-hand side of the flowchart or the right-hand side where you no longer have concerns, but like the first case I showed, might be doing something to support the family, referring them to local support services. So this to be used in conjunction with the wealth of information that you find in the things that Jasmine has already talked about and your local Safeguarding Children Partnership information. But I think this has stood the test of time and is quite useful for making the broad decisions about how concerned you are about a family, and it applies in all kinds of clinical situations. The second tool is for dental neglect, the three-stage management of dental neglect. And this arose out of Area Child Protection Committee procedures in South Yorkshire in Rotherham, where I was working at the time, that described how we could use a preventive single agency response to concerns about neglect. If more concerned, we could escalate that to a multi-agency response, liaising with other professionals, checking for child protection plan alerts, and agreeing a joint plan of action. And finally, if things were, if the situation was too complex or deteriorating, then referring to social services. And this was taken up and adapted for dentistry and is described in more detail, both in on the Child Protection, the Dental Team website in the Responding to Dental Neglect section, but also in the BSPD's policy document on dental neglect in children. And I tend to think about it in the sort of diagrammatic way, as you see on the right-hand side there. There are going to be a lot of children for whom we're doing that preventive single agency response. And our preventive care is going to make a difference, such as we nip the dental neglect in the bud. And with if we're setting targets, keeping records, monitoring progress, hopefully getting to a situation where we have less concerns about the dental neglect. Sometimes moving to that orange stage 2, where we've perhaps contacted school nurses, health visitors, maybe the GP, to make a plan for the child. And then only in the most severe cases, making a referral to children's social care. So that was the second tool. And then it leaves us with what to do about missed appointments. And for many years, that's been acknowledged to be a big issue for dentistry. There's an evidence base to show that missed appointments are a characteristic feature of dental neglect. They are an alerting feature of general neglect. They're a common factor in serious case reviews. That's what happens when a child dies or is seriously harmed as a result of maltreatment. There's consensus that they must be followed up rigorously. But I think the most interesting thing to do with missed appointments was a paper that reconceptualized did not attend to was not brought, suggesting that we think about it in a completely different way. Excuse me. So, did not attend or was not brought. This is based on the idea that the child has a right to healthcare. We need to assess the reason for the was not brought and consider its significance from the child's perspective. We need to document it and make a record of the action taken and the outcome. And I hope that nowadays we'd never get to a situation like you see on the right-hand side of the screen, which is a screenshot from somebody's R4 Clinical Plus record, showing just how many appointments have been missed and just what the child has missed out on. So around about 5 or 6 years ago, we decided that we couldn't put this on one side any further. We were spending a lot of time reassessing patients' notes after missed appointments, and it felt like I was always being asked to decide what should happen next. We felt that we weren't very standardized in what we were doing, and we wanted to so we'd done an audit and found that, you know, even with best efforts, it was difficult to make sure that no one slipped through the net. So we wanted to develop a pathway that would enable earlier and more consistent information sharing, that would involve the whole of the skill mix dental team in that process. It needed to be easy to follow, and importantly, it needed to have a defined endpoint. We wanted to get to a point where we had taken the necessary action, and that sometimes we could decide that there was nothing more that we could do, but that we had shared information appropriately. So we reviewed examples of DNA letters and policies from all around the region. We consulted stakeholders, including local named nurses and named GP for safeguarding children. There then this is what we came up with. So first of all, a flow chart that describes the process. Secondly, some template notes for, as I say, we're using R4 Clinical Plus, so electronic note keeping, and then some template letters. And the template letters, for example, are for every letter that we send out to patients, explains why it's important to have dental treatment, and that should the patient miss an appointment, then we may share information with other professionals. All of these are color coded, the letters are numbered, so that's designed to make it easy for the staff using it. So they include prompts for staff, so the flowchart and the template notes act as a kind of script, which I think particularly our receptionists find really useful. And then when we get to the final stage of the process, if parents have not responded to phone calls and letters, it's only at that stage that the dentist reviews the records, assesses the risk of harm to the child, and decides on any further actions that's needed. So that might be safeguarding actions such as a referral to children's social care, but it might be that we decide that currently the child is not at risk of harm, and we share information with their GP. So over the course of 8 months, we implemented this at a community clinic, where I think I was working just a day or two a week. We had over 1,000 dental appointments. 134 appointments were missed by a total of 91 children. We found that the staff followed the pathway for 84% from the start. And when used, 3/4 of the missed appointments were rebooked within 3 weeks after communication with parents. When we reached the end of the pathway, information was shared in 25 cases with general medical practitioners and other health and social care professionals, and that often prompted them to contact the family, and then the family to get back in touch with us. We asked in addition to the quantitative evaluation, we asked our staff how they got on with it. And here you can see some of the comments. They learned it quickly, they found it easy to use, they thought that it helped them to do a better job for their patients, and overall they thought it saved them time. They started referring to the different sections of the pathway as a was not brought 1 or a was not brought 4, in a way that really I hadn't expected. And we also did a small study with GPs to look at their perspectives, and they unanimously agreed that they valued receiving the information from us, and that they were the right people to contact. So all those documents have now been made freely available online as electronic supplementary files with a paper in the BDJ. And my co-author Jen Kirby worked on this project as a leadership fellow a few years ago. So the BDA have now adopted the pathway and helped with an implementation guide, which you can see the cover of there. We've added in a pink pathway for children subject to a child protection plan, and one for orthodontic practices developed in conjunction with the British Orthodontic Society. So those are just for some specific circumstances. And all the documents can be downloaded from the BDA's safeguarding page, and you see there's a table there to help you get them all straight. So we started off 15 years ago, dentistry rather left behind in the field of safeguarding. Few dentists were suspecting abuse of child patients, and even fewer were making child protection referrals. Even though we acknowledge that seeing children with neglected dentitions is something that the literature shows 60% of paediatric dentists So they see children with neglected dentitions on a daily or more often basis. We've just published in the last month in the International Journal of Paediatric Dentistry some data from paediatric dentists in the UK, where a survey showed that now 82% have at some point suspected abuse of a child patient, and 61% have now made a child protection referral. So a big difference compared to when we'd done the survey 11 years prior to that. So we're getting better, but there is still a long way to go in order to listen out for children and to be their voice when we have concerns about whether they are maltreated. So I've taken you through 3 cases. I've explained about 3 flowcharts that I find useful. I have had a hand in all 3 of those, but as I have no conflict of interest, I don't derive any monetary benefit from any of those. But I must thank those it's a team effort, and I have to thank my colleagues for working on all of those projects as well. And also BSPD and the BDA who 2 organisations who've hugely supported safeguarding children over the last 15 years. So thank you very much. That's the end of my bit. And so I'm hoping that somebody will chip in and pass on to the next speakers.
Just before, it's Kenny Gibson here, your facilitator. Just before we pass on to Millie and Deborah in order to get them lined up, I'm just looking at some of the open questions, Jenny, and they very much relate to having the confidence or permission to share data with others that can support the family, particularly permission from the family members themselves. How have you resolved that before I can maybe begin giving you some cues for those listening to this? How have you protected children by sharing data? What would you say was your greatest tip for that?
I think it's considering the child's best interests. Often questions come up about confidentiality, and I really don't see that in the same way as I did 15 years ago. If in order to make a difference for children, we have to share information. We have a responsibility to do that. In relation to the offering support, like the early help assessment that I mentioned, that is something that that can only go ahead with the consent of the family. So in that case, that was an open discussion with the mother, and we filled in the form, almost filled it in together. I read it back to her and checked that she was happy with the content before I then submitted that. But in relation to referrals for children where I think they're at risk of significant harm, you don't need, it's good practice to discuss with the family, and I think that is a good way of maintaining a rapport with them, and you can retain your working relationship with them. And there's evidence to suggest that being open and honest from the start results in better outcomes for children, but you don't formally need their consent to make a referral. Does that?
That's absolutely right.
Your question?
It does.
Are you happy with that as an answer?
I'm delighted with that as an answer, and I just need to speak to registrants on this point. There's an awful lot of anxiety, professional and personal anxiety, about whether we should or whether we can. Let me make it very clear. You can, you will, indeed you must. You have a professional duty to protect children under the Children Act, but also under Chapter 4 of the Working Together regulations about working together to protect children. So let me just give you my go-to place if I have a concern about child safeguarding. If my intuition is sparked and I am not content, that child is not safe. So are they vulnerable to harm, exploitation, or violence? There is something called a Section 254 of the NHS Act 2006 that allows me to use my clinical prerogative. And you're absolutely right, Jenny. We seek permission from the parent. If that parent declines, that is their prerogative. But it is my clinical registrant prerogative to refer that child. Otherwise, as you've stated on this call, all sorts of systems fall apart. So when there is a serious case review, the lack of data sharing is mentioned every time. When there's a domestic homicide review, the lack of data sharing is mentioned every time. So I want each one of us on this call, all 215 people, to be courageous enough to ask permission to share. And if they decline, record the decline, but then share what you need to share in order to protect that child. No professional registrant, in my experience, has ever been dismissed or lost their career because they've shared data to protect children. So thank you for that, Jenny. And hopefully it's responded to some of our colleagues' Q&As in the box. Thank you so much. I think we're now going to listen to Millie and Deborah, Millie Doshi and Deborah Manger, about adult safeguarding. So if we can get the ladies' presentation queued up. Over to you, Millie, and over to you, Deborah.
Thank you, Kenny. Everyone can see the presentation okay? Brilliant. Thank you very much for the invitation to speak this evening. As dental professionals, we all have our safeguarding training regularly, but sometimes when faced with safeguarding actually in practice, it can be difficult for us to put our training into practice, even for those of us who are used to working a lot with people who might be more at risk. It can be a challenge, but we all have a legal and ethical duty to protect adults at risk. And what I want to do over the next 20 minutes is probably cover quite a lot of the similar themes as the previous speakers, but just to use some scenarios to talk about, what would you do if you were faced in a situation where you suspected somebody might be at risk of abuse or neglect. So the first thing is we've heard, who is responsible for safeguarding in dentistry? And the answer is really all of us, as Kenny said, everyone that is involved in caring for patients. But it's really important that in practice, it's not just the dentist or the safeguarding lead, it's the whole team, because often it will be the dental receptionist or the practice manager who may notice something, hear something or see something when a person is in the waiting room, or it might be the dental nurse that the patient feels more feels that they can confide in more. So when we are working in practice, we need to make sure that we create an environment where everybody in the team feels that they have a voice. And sometimes speaking to the whole team, it can be something, a receptionist may not feel that they are able to say something if they are suspecting something is not quite right. So in our practice meetings, in our supervisions, it's really important that we have this environment where we share, we talk about safeguarding as something that is fundamental. And we've already heard it twice this evening, but this whole thing about professional curiosity, and that's, not taking things at face value. If we see something, if something makes us just, in our gut, just think there's just something not right about this, we ask those questions, because those questions may lead to answers which may lead to things that we need to go and work on or go and speak to protect people who are vulnerable. So, there are, for adults, what can be considered as abuse and neglect. There are lots of categories. I'm not going to go through all of these because we don't have time. But just what I have done is just put those things that occur more commonly at the top that we may see: physical abuse, neglect, self-neglect, psychological abuse as well. And what roles do us as dental teams, and that is the whole dental team, play in the role of safeguarding? Well, often we will be the team that see patients. Dentists are often people that see patients regularly across a lifetime, and we might be the ones that notice just something's not right. For example, somebody that's getting older who becomes more forgetful in coming to appointments when they've, religiously been coming to appointments every 6 months, or we see a sudden deterioration in oral health, or they just look tired, they don't look like themselves. As dentists, we might be the sort of professionals that are seeing people regularly, and might be the people that can notice something's wrong and can speak to that person so that they may get the support that they need. But also, adults at risk may have very limited contact with healthcare professionals. I noticed this a lot in the first lockdown, working in a UDC hub for patients who, were shielding and vulnerable. And the number of people that hadn't spoken to anyone, lived by themselves, had not had any sort of contact with any healthcare professionals, but were at risk due to a disability or mental health issues. And actually just having contact with someone was really important to them. And so we have to remember that we might be the only person that this person is seeing. So we do have a duty to really look at the person holistically. And again, if something doesn't feel right or we feel that they need support, be the person that can help advocate on their behalf. But also, we are experts in our field. So when we see somebody with, say, a physical, something that's happened to their teeth or their face, trauma, etc., this is something that we will have expert knowledge of. And so if we see something that doesn't quite marry up to their history, it might be something that we would pick up on, whereas our medical or other healthcare professionals might not pick up on. So it's important, again, that we're aware of signs and symptoms which may be a sign of physical abuse. And I've put it in red just to remind me that the impact of the pandemic will have had a big impact on abuse, and we have seen it. So in the first lockdown, there was a big rise in domestic abuse. We know that all types of abuse, financial abuse, mental health illnesses, have all increased as a result of the pandemic. But also, a lot of the people who have those characteristics that make them more likely to be at risk were those people who would have been shielding and isolating, and so will have had very limited contact with healthcare professionals. They're also the group that tend to have higher levels of oral diseases, such as dental decay, periodontal disease, and may attend dental practices when they have sort of more urgent needs. So again, we have to be, and again, we're seeing a lot of people that haven't been for years. They haven't had, they've had issues, in care homes, for example, attending dental practices because of, outbreaks of COVID, etc., in the care home. And it does mean that we have to be really vigilant of the signs that somebody might be being neglected or signs of abuse. Just a reminder about who really is an adult at risk. It is somebody that has health or care support needs, somebody who is experiencing or is at risk of abuse or neglect, and somebody that's unable to protect themselves because of their care and support needs. And the people that are most at risk are older people, people with physical, medical, learning disabilities or sensory impairments, people with mental health illnesses, and those who have long-term health conditions, and somebody who may misuse substances or alcohol. So going on to scenarios, and I'm just going to sort of focus on all the cases I've chosen, either where we have consent or I've made changes, so because of obviously identifiable information, and just run through, there's no right or wrong answer, but just sort of what would you actually do if you were faced in this scenario. So our first one is looking at Ola, who is a 26-year-old female patient who has quite a high caries rate, and she has a diagnosis of autism and depression, and she lives in supported living, and she's come to see you. You've not seen her before. She's seen a colleague. Your colleague removed a front tooth at the last appointment because she had pain. She's coming again, a scheduled appointment with pain, and you're removing another tooth. And when she comes in, she starts sort of asking about replacing the front tooth, and you're sort of it's Friday afternoon, you're talking about the fact that it's important that we try and stabilize the mouth first and deal with the pain issue today. And when the nurse goes out of the room, she sort of mentions to you, when it's just the two of you, that her teeth are not a priority because every day when she wakes up, she thinks about ending her life. And here you are in a situation, and I think when I was trying to choose scenarios, I was choosing the things that I think happen the most. And I think as a dentist, having that relationship with patients, often they will disclose information about their lives which may make you realize that actually there may be something here which puts them at risk of neglect, abuse, or self-harm. So what do you do in this scenario? You're in a scenario where you're in a practice, you've got a patient and they've opened up to you, they've disclosed that, they have that they're very depressed and, having suicidal thoughts. The first thing really is to assess, is there an immediate risk? Are you concerned that, that there is a threat to life or, and etc. If you think there is an immediate threat to life, then obviously you need to do what you can to reduce this, and this would be calling emergency services. In this scenario, I kind of felt that this patient said that these were thoughts that she had repeatedly. I didn't feel like it was an immediate threat that she was going to act on, but again, it's something that I needed to be aware of and do something about. So the next thing really is the capacity to consent to have they got the capacity? And actually, yes, they have a diagnosis of autism, they have a mental health illness, but fully able to understand all the information and make up a decision on for themselves, so they have capacity. Next thing is when somebody confides in us is really to start asking those questions. And the first thing is, are you getting any support? Does anybody, know about this? Have you spoken to anyone? And she was very open about it. She was like, yes, my GP is aware, I have a counsellor, it's just the way I feel. So in this scenario, you feel quite satisfied that actually, the patient, she's disclosed something to you, probably because she wanted you to know that the impact it had on, why her dental health was not her priority. But the scenario can be different. If she had no support, we would be the person that might be the person to offer to say, not to say, actually, I think you're at risk, I need to open a safeguarding alert about you, but more along the lines of, thank you for confiding in me. Would you like me to speak to anybody, because there are people that could help you, etc. And if the person says yes, then that's great, and then it is our duty to speak to their GP, try and support them get the right services for them. But the difficulty can be when somebody discloses information to you and they say, I don't want you to tell anyone. They don't want you to tell anyone. They want it to be confidential, and they don't give you that consent. Because it's that threshold. Because for somebody that has the capacity to consent, as has already been discussed, we sometimes have to, the decisions they may make may not be the decisions we would want them to make. And when patients are confiding in you, it's important that they have trust as well. But the threshold is important as well, because if you believe somebody is at risk, you may sometimes have to break that confidentiality to get them the support they need. However, in a lot of cases, if you think the threshold is not there, the best we can do is to make sure that we offer advice, we follow them up, and we record everything. And sometimes those decisions, it will be if you don't feel confident in making those, it might be speaking to somebody in the practice, somebody who has more experience of safeguarding, or even giving the safeguarding teams a ring and just asking for advice. Because we have a responsibility, and in this scenario, there was somebody that has obviously disclosed something. But actually what made me, I started thinking about it as she'd spoken about it, was when she'd come in, she'd sort of talked about her front tooth, and she said, well, actually I'm, and I could, as I started thinking about it, that she must be very conscious that she's lost the front tooth. And as dental professionals, there are things we can do, and we're taught at dental school that we have to, stabilize the mouth before we can think about replacing teeth, etc. But why not in this scenario, can we consider maybe replacing that front tooth a bit sooner? And I asked her, I said, does, having no front tooth, does that impact on your confidence? And she said yes. And that made me think, well, actually, let's make sure that as we are seeing this patient, we are thinking about maybe making a temporary denture or resin bonded bridge as her mouth is stabilized, because we can actually maybe help with her mental health. Because also not just in the aesthetics, but a lot of our patients will have, chronic pain, etc., which can be enduring. It can have a real impact on their overall health. And as dental professionals, there are things that we can do to sometimes help them. The important also of this case is the importance of keeping really good records and keeping those notes, because who knows who will be the next person that sees that patient, because it might not be you. And if people are disclosing things, it's really important that we record, what they've said, what we said, any actions and any follow-up. And in cases like this, it is important that we do follow up patients, because as I mentioned earlier on, we may be that professional that they feel that they can open up with, and feel that they confide in and that they can trust. And it could be at a follow-up appointment. They are, they may be asking for us to support them and help them get support. But also when we're talking about, mental health, I also wanted to mention that, it's not only our patients. The world is sometimes a horrible place. We've all been through a lot over the last 2 years, and really to keep an eye on our colleagues as well, because a lot of dentists, dental nurses, the whole dental team, there is a big rise in mental health illnesses. And there are lots of, we talk about it a lot more, which is great. There are organizations and there's websites such as, support for dentalteams.org, which talks about, well-being, etc. And the importance of us, keeping in touch with our colleagues, asking those questions if something doesn't, feel right, and just being kind as well. So going on to our next scenario, we have a patient who is 67 years old. He has dementia and he's living in a nursing home, and he comes in for an appointment for dental treatment. And it was a very hot summer's day, and he was wearing a short sleeved shirt, which probably was slightly too small for him. And a few buttons were undone at the top and at the bottom. And I noticed on his torso, I could see that it had these marks on his chest. And they almost looked to me like cigarette burns. And obviously this sort of, had alarm bells, and I sort of mentioned it to my nurse, who also had thought something very similar. So what do you do if you're facing a situation and he'd come in accompanied by a support worker? Well, the first thing, is this a person at risk? And yes, it was. This is an adult with dementia, quite severe dementia, and he doesn't have the capacity to consent to dental treatment. And so the important thing is to ask some questions. And it can be a challenge because, I'm 20 years been in dentistry, so I'm quite used to having difficult conversations, but maybe 20 years ago I wouldn't have been so confident about doing so, because you can be concerned about making an accusation, and what if I've got it wrong? And in this scenario, the questions were, not to the carers, like, has somebody been putting cigarette stumps on him? It obviously not that line of questioning, but oh, I've noticed he's got some marks. What are they about? And the carers mentioned that actually, yeah, he has a habit of picking, so using his nail and picking at his skin. But you left in a difficult situation there, because you obviously we all want to believe everyone, but here is a vulnerable adult, where two people have noticed marks on the body. And in this case, I decided that, actually I would speak to our safeguarding lead about it. But I was very open with the carers. I've said, I'm sure, that is absolutely correct. But because this person, this person is at risk, I just need to just make a note of it and notify, our team, because there is somebody at risk. And actually the carer that came was actually very, open, and was happy with us doing that, because again, they knew that they were working with somebody at risk, and the reason wasn't us. We were not making accusations. We were just raising things that needed to be investigated. And we did make a line of question and spoke to the care home manager, and somebody, the GP, was aware, and somebody went to the home, and it was found that yes, it was true. He did have this habit of picking, and that the reason I want to put this scenario in is because it is important that even if we think something is probably okay, when we are working with vulnerable adults and people at risk, it is important that if there's anything, we do follow it up. And again, we're not making accusations. All we're doing is we're having open and transparent conversations about people where we can share information just to make sure that they are safe. So just wanted to mention briefly about raising a safeguarding concern, and it has been touched on already, but the importance of it being factual. So really having all the facts there, not having our own opinions, etc. When we are filling in a safeguarding alert form. But also making sure that we have all the relevant details of the individual, because that's what we need to put in, making sure our notes are very, very comprehensive and using as much information as possible, not just one line that notice marks that this patient came in on, where the marks are, etc. Any actions taken is a question that you have to put on. So if you, for example, that you've had that conversation with the carer, it's important that, especially if the person has the capacity to consent, you on the form, you actually fill in whether they've consented to you giving to raising a safeguarding inquiry or alert. But also making sure that you put all the details of yourself as the person reporting it. What happens next, depending on the case, there will normally be a conversation with the adult or their advocate. Information is gathered to look at what sort of response is needed. Teams will help to work with the person to make sure to keep them safe. That's the main priority. A plan will be to look into their concerns. It may be that a safeguard, if it reaches a certain threshold, a safeguarding inquiry will be made. But also, if not, it may be that advice is given to the person or the advocate, or they're given information or social care support. But the most important thing is that people will check with the person that what they wanted to happen has happened, and where it is possible to do so. And again, Jasmine's mentioned the safeguarding app, which is great. Has been looking at it, and it's really good for having those contacts. So really easy to use as well. So our next scenario is of a lady who is 45 years old, Emma. She has moderate learning disabilities and she lives in a care home. She comes to the dental appointment and she looks very well cared for. For example, she's dressed all in purple, her nails are painted, her hair is done, and she's wearing a hat. And she looks really well. And the carers, they seem to have a very nice relationship with this lady. But as soon as she opens her mouth, you see a mouth like this. You have this horrible smell, her teeth are very mobile, her gums are inflamed, there's lots of plaque and deposits on her teeth. And it doesn't quite match with this picture of a very well cared for lady. So what do you do? And unfortunately, I'm sure for a lot of us who see people, adults who come in from care homes or who have support needs, we often do see suboptimal oral care. So the first thing, again, is to ask yourself, is this a person at risk? And yes, this is somebody with learning disabilities, and when you assess them for if they have the capacity to consent to say dental treatment, you find that they don't have the capacity. And you have to think, well, what is the risk to the individual of having a mouth like this? Well, we know it can cause pain, infection, the risks to general health. Having this much plaque could be a risk, a link between poor oral health and aspiration pneumonia. But you also have to consider other factors. So when patients come like this, what I normally do is I will get a toothbrush and brush their teeth and see how challenging it is for me, because sometimes there are people where toothbrushing is really challenging, but often in cases it isn't, and they let you completely brush their teeth, but the carers are saying they don't let them brush their teeth. So here we have a case of neglect. But we do have to consider that sometimes neglect isn't always intentional. So it could be because the care home hasn't got the governance in place and training for staff to enable them to support the people with mouth care. And actually we find that when the Mental Capacity Act came out, that often people would use that as an excuse or as a reason, not an excuse, probably the wrong word, not to carry out mouth care, because they say, well, they don't have consent, we can't restrain people, etc. So a plan for this is, obviously you're not going to raise a safeguarding alert for every single patient that comes in with a mouth like this, but a plan would be to speak to the care home manager, because often people come in or with support workers or key workers who unfortunately are not their key worker and don't know that much about the patient. But a conversation with the care home manager, or a very good worded letter, which sort of highlights the fact that you've noticed that somebody has come in, their oral health is very poor, they've enabled you to brush their teeth, the risks of their poor oral health, do they need any help, signposting them to training is very important. And sometimes copying in I always copy in their GPs, because oral health, we know, has big links to general health. And I think this is something that is being more appreciated. And so hopefully by raising this as something that you are concerned about, and maybe supporting them, giving them a plan of how you would advise that they do support this individual, so supporting her with mouth care, like techniques to brush teeth, etc., things might improve. So it's important that you review the patient quite regularly and follow them up and document all of this, because if things don't improve, then that might be a sign that, if mouth care is not being done, what else is not being done? And it might be something that actually we do need to escalate if people are coming back repeatedly with mouths like this. And generally, I feel that actually with enough now with more things like the CQC on board in terms of oral health and care homes, etc., that by raising it and by trying to be supportive, sometimes cases like this, mouths do actually improve, which is what we want. And I also wanted to sort of mention that the was not brought, which Jenny has obviously talked a lot about for children, also does apply to adults at risk. Because if an adult is not brought in for an appointment, and somebody that needs support, we do need to follow it up. We do need to find out why. And again, with the COVID pandemic, we've seen quite a lot of a rise in people not turning up. And often this is because somebody we find that there are waves, but somebody in the care home has COVID. And that will mean that the whole, that nobody goes anywhere for 2 weeks. So although it's not intentional, again, I do feel that actually during the pandemic, there are a lot of people that just have fallen through the system that we just now need to try and reach out and support the best we can. So just thinking about time, I'm going to skip the next scenario because I know that I want to pass on to Deborah, who's also got some cases that she's going to discuss. But just really in summary, safeguarding adults is, at risk is a responsibility of everybody in the dental team. And it's really important that all staff and the whole dental team should be aware of how and who to report concerns to. Thank you for listening, and I'm just going to pass you over to Deborah, who's going to talk to you about some cases as well. Thank you.
It's obviously late in the day, I was on mute. So when I got invited to come and join this seminar, I was just full of ideas about what I could talk to you about, and just listening to everybody this evening I've been making notes throughout. So we've talked about omission, and I do have some cases of omission, but actually I think what I'm going to do is I'm going to share with you two very different cases. One is you will, I suspect, because people are living longer, because people have chronic illnesses, because that they often have family involvement, you may hear about people who come along with families, and the family will say to you, I've got lasting power of attorney for mum or for dad. And, or as I had in one case, I'm the court appointed deputy. So I make all the decisions. I make all the decisions for their healthcare. And I had a case of a middle-aged female in her 40s, and very severe autism, had been in care for pretty much most of her life, and as an adult, that is, and dental care was really difficult. In a very caring environment, they did try to clean the teeth. We did try to do examinations. Perio, the gum condition was not awful, but and she still had a good complement of teeth, but you could see that there was periodontal disease. The parents became obsessed with her having a better dentition, but in order for that to occur, they were starting to demand general anaesthetics every 3 months. We didn't do them, by the way. And they were starting to demand that she had advanced restorative procedures. They were talking about removing mobile teeth and putting implants in, and it was starting to get very, very heated. And the parents decided they were going to try and take her from the home, and this person struggled to leave the home. They would often need physical support so that they wouldn't attack people, to a private dentist to get an assessment for implants. I was starting to get quite anxious about what might happen to the dentist they took her to, because it might have resulted in harm to both. Got involved with the adult safeguarding team. They were fabulous. We held a conference. The parents came. They insisted on it being recorded. That was fine. And we needed to remind the parents that having lasting power of attorney, or in this case, being a court-appointed deputy, does not give you permission to act outside of somebody's best interest. So if you do get somebody coming along and they have a family member and they go, I've got lasting power of attorney, that's absolutely fine. It's great. It means that somebody's there to be their voice, but they are not to be the voice of where it lacks reason and lacks any interest for the individual. This was about cosmetics. This was about an image they had of their daughter, which I totally get, but you cannot then do treatment that isn't outside their best interest. So in this particular case, we had to go to the court as well to indicate to the judge that they were trying to act outside of their daughter's best interest. I totally understood why, but it's still not acceptable. But it is not inconceivable that you will meet people who, like I say, they'll come along and they say, I've got lasting power of attorney for mum, I can sign the consent form. They can't. Not with a lasting power of attorney, they can't. They could if they had a court-appointed deputy status, but not lasting power of attorney. They join in the conversation, you discuss the best interest for the individual, and you act in best interest. But nobody gets to act outside of that. So it's just to draw your attention to that. I had a lasting power of attorney for both of my parents, and it does not give you carte blanche to agree to all sorts of treatment that not in their best interest. So just thought I'd bring that to your attention. The other I wanted to raise, and this could be children or adults actually, was a woman in her 30s, was referred to the service by a general dental practitioner for treatment, multiple decayed lesions, very poor oral health, very poor oral hygiene in particular. The individual was referred because of lack of capacity. They have cerebral palsy, they are a wheelchair user, and they have carers. The individual came in for their assessment, and they were quite tearful, quite anxious, didn't know what I was or wasn't going to do. I assessed their oral health. It was very poor. It's some of the poorest oral hygiene I've ever seen. And once we'd calmed the young woman down, she did have capacity. She was very clear. I don't clean my teeth. I don't want to. I do enjoy drinking chocolate half a dozen times a day. And we discussed in detail what she thought she needed to do, and would she be prepared to adjust some of her lifestyle factors, and what treatment did she want? What did she want from me? She just wanted the tooth out that was hurting. It had been hurting now because of the referral for about 3 months on and off. So I took the tooth out, had her consent, and did need to come out. And the rest of her teeth were all very decayed. Most of them would be unrestorable. And she didn't want fillings anyway. She certainly didn't want advanced or restorative procedures. And she didn't want a denture right at this point either. She didn't want her teeth removing in their entirety. She just wanted it doing when they hurt. I sent her away, got her back. We kept going with appointments for a little while, just so that she built up confidence, as Millie has said, and as Jenny has said, and Jasmine, this is about trust. So this was about me having a relationship with this woman. She was very clear. She understood the consequences of not having the treatment. She knew what sepsis was. She knew what the risk was. Her carer was a support worker. They helped her with physical activities of daily living, but not with her managing her bank account and not with her managing any other issues. She was fully capacitous. So what I did was I went back to the referring dentist and said, this lady does actually have capacity. What you don't like is the fact she doesn't want the treatment and that she's making, in your opinion, a bad decision. And I would put in brackets, in my opinion as well. It was I thought, a very bad decision. And I'd had that open conversation with her because we had a relationship by this point. And she said, all I want from you, and I'm paraphrasing, all I want from you is to be able to come when I have toothache, and I may choose to have a tooth out at that point. And I'm not going to change my lifestyle. And I think for most of us, we sit here and think, why would you do that? It doesn't matter. It doesn't matter. She said, this is what I want. My life is difficult enough. I love drinking chocolate. I do not want to clean my teeth. I just want help when I've got problems. And I don't think we realize that safeguarding includes human rights. And it is her right to make a bad decision. It is really hard as a clinician to deal with that stuff. And interestingly, the dentist that I was talking to at this point, then a few weeks later, agreed that it would be really good to have some conversations in the practice about consent and what that meant and how people can make bad decisions. And in my former role to being in HEE, I was a deputy medical director. And I also I helped the safeguarding team with a man who used to go for diabetic retinopathy screening. He had type 2 diabetes, and he was developing signs of diabetic retinopathy. He did not want to go to hospital to get it managed. He wanted it reviewing so he knew how close he was to going blind and so that he could put in place measures so that he would have help at home. But he eventually went blind. And again, that was referred into the safeguarding team, and they asked me to help them talk to this gentleman. But again, he was making a decision that was well informed, not the decision I would make, and he chose not to have it treated. And I think we get very uncomfortable when people make decisions that we think are bad decisions, and we don't know how to respond to them. And so I would just urge you, when you do hear people thinking that they're making a bad decision, just sense check they've got capacity. It's quite easy to do, really. In the case of the woman, you know, the support worker was there just for physical activities of daily living, not for anything else. And assuming they understand the consequences of not having treatment done, so infection, sepsis, and you clear they understand it, then you have to go with that. It's really hard. That what happened with this woman was that she then ended up having toothache for way longer than she needed because we doubted her capacity. So I've just put that in front of you. And I would say thank you for listening to me ramble on. Thank you.
A tour de force of rambling on, Deborah. Thank you very much for raising those really important things. As Lord Mumby said about adult safeguarding, what is the sense of safeguarding me if all you do is make me miserable? I think there has to be this balance and best interests around capacity to make unwise decisions, as we all have done in some of our lifestyle choices.
Yeah.
And this is going to become really critical because as of 2 days ago, the government has launched a consultation on the Mental Capacity Act that includes liberty protection safeguards, or as they were called and continue to be called, deprivation of liberties, safeguards. And whilst currently they only affect adults in hospitals, moving forward for community specialised dentistry, they will also include any neutral setting venue and 16 and 17-year-olds. So this idea of making sure that the people you're coming in contact with have capacity, and it may not be our interpretation of their best interests, but as I've said before, we must not get caught up in our conscious or unconscious bias. So it's a really helpful case. Millie and Deborah, we do have one question related to this, and that was, from Myra, how do we support if staff genuinely can't manage to assist people with brushing, a resistant or a non-brushing patient? What's your top advice for that? And then I'll sum up.
Oh gosh, I think, Deborah, this could be a webinar in itself about brushing. Trying to think how a quick answer. There are people where it is really difficult, and care resistant behaviour is probably the #1 reason why mouths and teeth are not brushed. But it doesn't mean we don't try again, and we keep trying, and we use different techniques. There can be things, what do they like? It can be distraction, it can be music, it can be brushing people's teeth when they're in the bath, it can be using the right different types of toothpaste, it can be in the mirror, them doing it, you doing it afterwards. There are lots of things. There are people where it is really, really challenging, but there are a lot of people where it is not so challenging, and they can get the support if staff have the right training. I don't know if Deborah wants to.
And I think the issue of clinical holding is really important, and to have a discussion about what gentle clinical holding can mean, and equally giving people devices. So we would make available to them. So we would wear, I'm sure you do, Millie, those devices that you put over your finger, Betty wedges, they're called. And you put a device over a finger and it goes in between the teeth, and you're not going to get bitten. Well, you just not. But people are often scared of being bitten as well. So showing them techniques to avoid that is really, really important. But as Millie said, there will be people. And it is always worthwhile trying to do it yourself, as Millie points out, because if you fail and you've got all the tools and the dental chair and all the rest of it and the kit that you need, if you can't, then you do need to just change your perspective ever so slightly and try and work and just keep saying I think actually repeating the activity in the care home in a favourite setting is it's often people who are in care where this happens. And just, you made me smile when you mentioned the bath, Millie, because I decided to demonstrate once, it was a number of years ago, that it was going to be possible because this person really liked a bath. So I went to show them, and he pulled me in virtually. I was virtually submerged. So we decided that wasn't a good plan. But I think it's important to try and utilise favourite environments and favourite people as well to help with the brushing.
Yes. People, particularly in care, we do have our favourites, they have their favourites, and I agree with you, that trusted professional.
Yeah.
I'm just going to summarise. I think we've covered all the questions. I'm sure there will be more. And as a team of experts, I'm sure we will respond to ongoing questions. But for the 210 people that have stayed on this webinar, thank you so much. You are exhausted, your resilience is low, and you're all recovering from the traumas and tribulations of 2 years. But you've taken 2 hours out of your time to listen to some of the most compassionate leadership I've heard in a long time about safeguarding. For me, whether it is Jasmine or Jenny or Millie or Deborah, there's one thing clear about NHS dentistry. As a team, as a group of team players, you really do want to get to know the person you're working with, the patient, their carers, because it's that ability to understand their trauma, that then bespokes or gives a unique care plan. And I've heard some glowing examples tonight of how, whether it's children or whether it is adults, that you have shown that light on understanding the person's trauma before developing their unique strength-based approach. And I applaud you for that. That is not only quality dentistry, it is effective safeguarding. We've heard today as well about making notes. We've also heard time and time again, it is about the we decision. You are not alone when making a decision about someone's safeguarding. We heard Jenny talk about the team approach to decision making. We heard Millie and Deborah talking about the we decision with colleagues and dental nurses and other colleagues in the dental practice. So if I had one word of advice for people in dental teams, it is everyone's business to safeguard, but turn to a colleague and just share your concerns and then work through that process. Are my concerns genuine? Are the signs I'm seeing? Is my intuition correct? The next thing you need to do is either make a referral if you think it's serious enough, but always contact someone outside your practice just to make sure that that person, that child, that family, that adult get the support they need. Many of us in families can actually deal with safeguarding moments, but we need to be handed into those strength-based approaches of community assets, domiciliary assets, or primary care assets. No one in this call can fix everything that is wrong with safeguarding. But what we can each do is we can listen to our patients, we can listen to our colleagues, we can support them to be confident in their disclosure to us. We can believe what they're saying, we can trust, we can let them trust us, and then together we can do something with that person. You've been listening to some of the most awesome dental safeguarding I've heard. So for those of you on this call, remember, this in terms of your learning is definitely level 3. I'd ask you to go over this recording again and begin thinking, what have I learned about from these safeguarding dental practitioners? What will I change in my practice the next time I come across a child or an adult that I feel needs safeguarding? But more importantly, to the facilitators, come back and ask them what more you need to learn about. Thank you for being on the programme tonight. Thank you for listening. And huge thanks for all you do for safeguarding your patients. Thank you very much.
Thank you, Kenny. Absolutely wonderful. Brilliantly chaired, and the presentations absolutely amazing. Each one of them was absolutely perfect, and I think you've all got through so much tonight. And it's thank you so much, everybody. So as Kenny said, thank you so much for approving this at level 3. So good night, stay safe. Okay, take care, everybody, and thank you so much tonight. Okay, good night.
Thanks, everyone. That was superb. Thank you.
Thanks, Simon. Cheers, mate.
Good night.
Bye-bye. Good night, everybody.